Good evening. Thank you for the invitation and the opportunity to share with you some thoughts about exclusive enteral nutrition and its role in Crohn's disease. I'm going to mention some key details of a recent case, talk a little bit about aspects of exclusive enteral nutrition as used for Crohn's disease, and touch on some work looking at the mechanisms of exclusive enteral nutrition. The rationale of this latter aspect in particular is that with understanding the mechanisms, hopefully we can enhance our understanding of the pathogenesis of the disease itself. So recently we saw a 12-year-old boy from Nepal originally, and he presented with a 6-week history of lethargy and weight loss. He denied any diarrhea, he denied any hematochezia or abdominal pain. His systemic inflammatory markers were markedly abnormal with hypoalbuminemia, raised CRP, ESR and platelets. His fecal calprotectin was also elevated above 800. He had an initial ultrasound that showed ileal wall thickening. And his chest X-ray and quantiferon gold were negative, excluding tuberculosis. Proceeded to have definitive investigations. The most notable features were aphthoid ulcers in the antrum and in the first part of the duodenum, with patchy ulceration in the ileocecal region. Histologically, he had granulomatous ileitis with active and chronic inflammatory changes noted in the upper and lower gut. He proceeded to have an MR enterography, and this documented 25 centimetres of ileal wall thickening with no additional small bowel involvement. He commenced exclusive enteral nutrition shortly after this. He used a Fortisip, a polymeric formula. By day 3, he'd already taken the required volume, 8 drinks a day. When we saw him after 2 weeks of exclusive enteral nutrition, his inflammatory markers were improving nicely. He'd gained more than 1 kilogram, and he was already having improvement in his general well-being and energy, such that he'd been able to get back to whole days at school. We saw him later in the 7th week of exclusive enteral nutrition. His inflammatory markers at this point were essentially normal, and his calprotectin had improved significantly down to 187. He'd gained over 3 kilograms, was doing well symptomatically with no limitations of daily activities. This management is ongoing. So, exclusive enteral nutrition can help with Crohn's disease. The initial reports of EEN date back to the late 70s and early 80s. One of the initial controlled studies was conducted in Ireland, comparing an elemental formula to oral corticosteroids in adults with Crohn's disease. These 2 interventions were shown to have similar outcomes. Subsequent studies, a number of subsequent studies have shown that polymeric formulas can be just as effective as an elemental or semi-elemental formula. And furthermore, a number of studies showing equivalent responses to steroids in children. More recently, exclusive enteral nutrition is now included as a recommended first-line therapy to induce remission in children with active luminal Crohn's disease. And although I'm focusing upon children and adolescents in my summary of this data tonight, there's also clearly data showing that exclusive enteral nutrition can have roles in adults as well, although it tends to be considered less often. Overall, general feeling is that EEN induces remission in at least 80% of those with newly diagnosed Crohn's disease. The outcome is probably less in those with long-standing Crohn's disease. As well as inducing remission, there's clear benefits in terms of nutrition with decreased disease activity. And some data illustrating that disease location is probably not directly related to outcome. Standard protocol in our hands, a polymeric formula, typically for 8 weeks and exclusively, with no solid food or habitual foods over this time. We permit children to have water and sugarless chewing gum. The volume required is worked out on estimated energy requirements. And we see children in a multidisciplinary setting for a couple of weeks during the 8 weeks of treatment, and liaise closely with the families, supporting and encouraging along the way, recognising that this is a big change for the child and typically for the rest of the family as well. Most children in our hands would drink their required volume orally, a small number needing a nasogastric tube to give additional volume or to give supportive volume. Many studies showing reduced disease activity, and this is from some years ago, showing decreased pediatric Crohn's disease activity scores, many by 2 weeks, further number of children in the following 4 and 6 weeks. Number of studies showing improved mucosal appearance endoscopically, and in particular achieving mucosal healing. This Italian study compared children with a polymeric formula to those that were receiving corticosteroids prospectively with repeat endoscopic assessment at week 10. 3/4 of those treated with exclusive enteral nutrition had mucosal healing at that time point, compared to only 1/3 of those treated with steroids. In addition to impact upon luminal disease, there's also a number of effects outside the gut as well. So several studies showing improved bone health. In this study, we evaluated markers of resorption and new bone formation in children treated with exclusive enteral nutrition, with comparison to a control group of children without Crohn's disease, who were well and growing well. Serum cross-slapse, a marker of bone resorption, decreased over the 8 weeks, whilst bone-specific alkaline phosphatase normalised, and both of those markers returned to the control values by the end of 8 weeks. This study didn't look at bone densitometry, but other reports have indicated improved bone densitometry in addition. How about the longer term effects? The study looked at the outcomes over a 24-month period, at least, in a group of children treated with exclusive enteral nutrition and a comparative group of children treated with steroids. Those that had been treated with exclusive enteral nutrition had lower disease activity scores at 6 months from diagnosis, had lower steroid exposure overall by 24 months, and had better height gains over that 24-month period as well. In addition, in this cohort, exclusive enteral nutrition, those treated with exclusive enteral nutrition had less likelihood of relapse over that 24-month period. So some protection with maintenance of remission. Numerous studies showing enhanced nutrition, with weight gains being typical and, in my mind, expected over a period of exclusive enteral nutrition. Some of these changes in nutrition are rapid, and IGF being one example of this. So in this data set, insulin-like growth factor 1 improved in the first couple of weeks of a course of exclusive enteral nutrition in this series of children. And the mean level at 8 weeks was certainly greater than at baseline. So much of this improvement happening in the first few weeks. So in summary, in terms of an overview of exclusive enteral nutrition, clearly has a role in the induction of remission in children with active Crohn's disease. In addition, it's steroid sparing, it's enhanced bone health, high rates of mucosal healing, and significant nutritional benefits as well. How might this happen? How could EEN lead to these positive benefits? As mentioned earlier, this is important in terms of optimizing the therapy itself, enhancing the use of EEN with enhanced understanding of the role and the benefits, and also hopefully improving our understanding of the underlying pathogenesis of Crohn's disease. Numerous benefits have been suggested, and there's data supporting a number of these. These include direct anti-inflammatory effects, modulation of the intestinal microbiota, effects upon permeability and other aspects of barrier function, and innate defence mechanisms that may be activated as well. I'm only going to talk about 2 of these just in the because of limitation of time, but there's data looking at these other aspects as well. So firstly, the anti-inflammatory effects of exclusive enteral nutrition. Much of this work is in vitro, but there is in vivo and animal studies as well, so showing the same features. In this model, intestinal epithelial cells are triggered with a pro-inflammatory cytokine such as TNF, or in the black bars, interleukin-1, leading to interleukin-8 production, with this being the key output in this model. In this data, the cells that were treated with polymeric formula following exposure to a pro-inflammatory cytokine had reduced IL-8, suggesting a beneficial anti-inflammatory effect. Taking this a step further to a microarray, numerous genes related to the NF-kappa B pathway in particular were downregulated following exposure to polymeric formula using the same sort of model. And some rtPCR confirmatory changes, with the black bars being the positive effect of the pro-inflammatory cytokine, and the grey bars being the cells treated with polymeric formula, And taking that to the next step in terms of the protein response, again, those cells that were treated with polymeric formula as an anti-inflammatory agent had a marked reduction in the response in terms of production of IL-8 and, in this case, IL-6. So is this one particular component of the formula, or is it the formula in its entirety? So we've started to look at this and trying to tease this out a little bit further, and looked at a number of constituents within the polymeric formula. In this data set, again using the same sort of model in terms of TNF triggering the IL-8, looking at glutamine, arginine, vitamin D3, and then a combination of each of those 3 constituents. And each of those 4 experimental settings lead to a reduction in IL-8, but the combination having additional benefits than each of the constituents in turn. None of those, excuse me, none of those experimental settings had an impact upon cell viability in this model. How about if we enhance the amount of those active constituents? So in this slide, we see the positive effect of TNF. This is the effect of the standard polymeric formula, showing a significant reduction in IL-8. But if we enhance the amount of the arginine and glutamine, and within an enriched formula, we see further significant benefits. Just to add to the mix, we looked at the effect of curcumin and then looked at a novel polymeric formula with enhanced levels of arginine and glutamine and curcumin, showing a significant further reduction in the IL-8 response. This work also looked further at the NF-kappa B pathway, looking at the I-kappa-kappa activity. And these data are reported as percentage from the control, from the positive control. Over on this side in the orange is a known inhibitor of I-kappa-kappa. And we can see that if we have two doses or a dose-dependent effect in terms of glutamine and arginine, showing further reduction in the IL-8 production, in the I-kappa-kappa activity, with curcumin also having the same effect. And the three of those reagents having a further additive anti-inflammatory effect, switching off I-kappa-kappa. Moving along to look at two aspects of innate defence, and this is looking at two antibacterial proteins, innate defence proteins made by epithelial cells. There's also data looking at permeability and other aspects of barrier function, and I'm not going to touch on this tonight. Intestinal alkaline phosphatase has a number of effects following production and then secretion by epithelial cells, in particular changing interaction between bacteria within the lumen and the epithelial cells, as illustrated in this cartoon. So our work in similar epithelial cell model showing increased production of alkaline phosphatase following exposure to polymeric formula over a period of time, in this case up to 72 hours. If we look at this output in an immunofluorescence experiment, this is the baseline level of alkaline phosphatase, and this is the 72-hour setting, showing a marked increase in alkaline phosphatase produced by these cells over that time period. How about CCAM6, a cell adhesion molecule, part of a family of CCAM proteins expressed on epithelial cells. And our data shows that polymeric formula, again, trying to imitate the in vivo setting, using the same in vitro models, showing a dose-dependent increased level of CCAM6 protein being produced by the epithelial cells. And furthermore, showing upregulation at the mRNA level, with the effect of polymeric formula being similar to a positive control interferon gamma. If we look at the production of CCAM6 in an immunofluorescent experiment, the control on the left side and the treated cells on the right side, showing a marked increase in CCAM6 protein produced by the epithelial cells and secreted into the media. Furthermore, The secreted CCAM6 is able to bind a bacteria, in this case AIEC, E. coli, adherent invasive E. coli, showing increased absorbance with in a dose-dependent fashion in terms of the amount of polymeric formula, and then showing that the formula binds the E. coli such that it does not grow subsequently and expressed in terms of the colony forming units. So they're summarising this effect in terms of CCAN6, showing that polymeric formula increases production and secretion of CCAM6 from the epithelial cells into the media, and in this case then binding bacteria, the AIEC, and stopping the interaction between the bacteria and the epithelial cells. So CCAM6 acting as a decoy. So in conclusion, just this very brief summary of exclusive enteral nutrition. There's clearly many key roles, although the paramount role is inducing remission and active Crohn's disease, with those other benefits including enhanced bone health, avoiding steroids and the side effects thereof. There's a number of mechanisms that appear to be important in terms of how exclusive enteral nutrition may impact active Crohn's disease. I haven't mentioned the impact upon the microbiota or upon aspects of barrier function. I have mentioned and demonstrated some of the data looking at the anti-inflammatory effects, and this in vitro work is backed up by in vivo work as well. And I've also shown some data looking at enhanced innate defence, particularly in terms of the production of proteins such as CCAM6, where they may have a decoy effect, binding bacteria and reducing interaction with the epithelial border. So although there is a lot that is known about exclusive enteral nutrition in terms of some of the things I've touched on tonight, there are still many questions left to answer. I'd like to thank you for your attention. I'd be happy to answer questions and clarify if as required. Thank you very much.